Hello friends, let's talk thyroid. So today we will be discussing about hyperthyroidism in pregnancy. The most common cause of hyperthyroidism in pregnancy remains Graves' disease. So that is the most common cause. So if some lady is already having pre-existing Graves' disease, is already on anti-thyroid medication, so what you need to do is right after conceiving, you need to change from methimazole or carmimazole, whatever was the previous anti-thyroid medication, to propyl thiouracil. Propyl thiouracil can be continued up to 12 to 14 weeks. Then after that, again you revert back to need to revert back to methimazole or carmimazole. So that is usually recommended because propyl thiouracil can cause severe hepatotoxicity. There are case reports of acute liver failure with propyl thiouracil. So long duration of propyl thiouracil is usually not recommended. So this is the recent change in management of Graves' disease and pregnancy. So this you need to be very careful about. Another very important aspect is how to monitor. So you need to maintain the T4 level in the upper half of normal. So don't try to normalize TSH. So the TSH will remain low. The monitoring for Graves' disease or any cases of hyperthyroidism will be by T4 in pregnancy and not by TSH. So if you are measuring free T4, then you can just keep the free T4 level in the upper half of normal, near the upper half of normal for that lab or for that assay. But if you are measuring total T4, what you need to be careful about is that because of increase in thyroid binding globulin, the total T4 cutoff changes. So if the total T4 cutoff for a lab is like 12 microgram per deciliter, then for pregnancy, because in the increase of TBG, you need to take the cutoff as 18 microgram per deciliter. So your target will be to keep the T4 value in the range of 14, 15 or 16. So even though it's apparently showing that the T4 value is high, you should be maintaining the T4 in that range and don't look for TSH. The good thing about many of the cases of Graves' disease are there is a decreased requirement for medication during the later half of pregnancy. So the Graves' disease often tends to go into remission in the later half of pregnancy. So you can gradually decrease the dose of the anti-thyroid medication. Another very important aspect where we often get confused is that we get this transient thyrotoxicosis related to gestation, related to the increase in HCG level. There the T4 is borderline elevated or usually low, high normal. The TSH can be low. So this usually occurs in the first half of pregnancy, and we can safely follow these patients up without adding any anti-thyroid medication.